So our mouth is very related to the rest of our body, and I think we need to stop separating it. So most of medical doctors get about an hour of training on oral health, really, in their whole medical career. So that's where your dentist and specialists can come into play to help guide you with taking care of that part of your body as well, because it's all connected.
Today's guest is Dr. Andrea Johnstone, a board-certified periodontist serving Toronto and Grand Cayman and founder of a female-led specialty practice. She helps women protect their smiles through midlife with cutting-edge care for gums, implants, and regeneration, because your smile should age as confidently as you do.
Welcome to the show.
Thank you. It's so nice to be here with you ladies.
Well, thanks for coming on and talking about this. And like we were just talking before we even started, I don't actually even know anything about periodentistry. Is that how you say it? Periodentistry?
Periodontics.
Periodontics, okay. Yeah. And how they really play a huge role in where we're at in midlife. Right. So for any of our listeners who may not know, I didn't, what is the difference between a periodontist and a dentist?
So a periodontist is a specialist in dentistry. So in Canada anyway, there's about 9 recognized specialties, and periodontics is one of them. So we have additional training on top of dental school. So I have my DDS degree, which is a Doctor of Dental Surgery, and then I went back to do a Master's of Science in periodontology. So I did a 3-year program at the University of Toronto on top of my dental degree. In my case, I also did an additional year of hospital training, which is very common for specialists. A lot of us go on to do what's called a general practice residency, which are typically at hospitals. I did mine at Mount Sinai Hospital in Toronto, which is a huge hospital. So I was there for a year, which is invaluable for my career at the time, because I really learned a lot of hospital-based dentistry, interactions between medical issues and dentistry. And that was kind of a gateway for me to go into specialty training, which I did at U of T. And part of the training there is you have to do a master's research project. So I had to defend a thesis. I did a research project on actually neutrophils, which are white blood cells, which are predominant in your mouth. And I did a research study on those. And interestingly enough, I was pregnant with twins at the time. So I defended my thesis as I was breastfeeding my twins. So it was a very stressful day in my life. I had to stand up in front of 5 men for 5 hours as my breasts got bigger, and it was like my breast. Anyway, it was very stressful. But periodontics is basically supporting tissues of the teeth. So it's the gums and the bones. So that's our specialty. So we're surgical specialists. So we also specialize in the placements of dental implants. And usually we have advanced training in things like sedation and also in dealing with medically compromised patients in a clinical setting.
Now, when it comes to women in midlife and hormonal changes during perimenopause and menopause, how does that affect gum health and bone health in the mouth?
Right. So we're finding that it really does. It has a surprising effect on both our gum and bone health, and that happens in a few different mechanisms. So really, we know that estrogen has a very protective role in terms of inflammation and in terms of bone health. So in perimenopause and in menopause, which is near and dear to me right now as I'm going through it.
All of us sitting at the table.
Right. So we start to see a change. So as our estrogen decreases, it kind of shifts our body into more of a pro-inflammatory state. And I noticed that myself. My joints hurt, like everything hurt. So we see that in the mouth, and we see that our mouth actually has a lot of estrogen receptors. We also see, so we can go from, in our mouth, we kind of are doing the same thing, our regular oral hygiene routine, but then in menopause, that may shift us to have more inflammation, despite the fact that nothing has changed, right, in terms of our home care. We also see changes in our bone health, and this is a really important one. So as estrogen decreases, we're going to see an increase in the turnover of bones. So there's cells in our bone that are responsible for turnover, and in normal bones, there's kind of a yin and a yang, right? So we have our osteoblasts that are responsible for forming bone, and then we have osteoclasts that eat away the bone. Decreased estrogen increases those osteoclasts, so it's going to eat away the bone more. So that happens also in the mouth. And our mouth, our alveolar bone, which is the bone that holds our teeth, is always in a state of high-ternal chewing and things like that. So we do see changes in postmenopausal women that they have this higher rate of bone resorption around our teeth as well. So if you go into menopause with existing gum issues, those can be accelerated during menopause for sure. The other thing that we see is changes in salivary flow. And this can be really real for a lot of women.
Is this the dry mouth that a lot of women? Okay.
Dry mouth or even burning mouth syndrome. We see that a lot. And I feel bad for many years when I wasn't going through this, or maybe it wasn't talked about as much, because I can tell you in dental school, we never really talked about this stuff. We never really talked about how hormones can affect women. All we would say is, yep, in the 5th decade of life, women may experience dry mouth. In life, they may experience more burning mouth syndrome. But no one ever said it could be because of drugs. It just was never really talked about. But I find that's menopause in general now, right? We're talking about it more and more. So salivary changes are very real. Dry mouth can, so decreased salivary flow can lead to all sorts of issues orally. So the saliva is meant to be very protective in nature. It lubricates, it washes away bacteria, it buffers it, it neutralizes it. So when we see a shift in dry mouth, that can cause a shift in the pH of our mouth. It can also cause a shift in our oral microbiome, which is so important. And we're starting to understand that more and more. It used to be that we just wanted to kill all the bacteria in our mouth. Well, we don't want that. And we know that now. We want a healthy microbiome. So having good salivary flow is important. And that shift in menopause can be real for a lot of patients.
When it comes to like the infected gums and gum disease and everything, a lot of it is the way that you would notice it is through like bleeding gums, gum sensitivity, swollen gums. When is that normal? And then when is it like red flag? Because I know that sometimes use dental floss and I'll have a little bit of bleeding and that kind of thing.
So I would say I wouldn't panic if you saw once in a while a little bit of blood with floss. That's probably because something was stuck down there. There was some plaque and you've got it out. And usually it'll go away within a couple of days. Bleeding is never normal. I mean, I tell my patients, if you were to brush your hair and see blood on the hairbrush, you'd be like, oh my God, there's a problem here, right? So brushing your teeth, we should not see blood on our toothbrush on a day-to-day basis. So blood is definitely a red flag. Now, a little bit here and there. Sometimes if you get a little lazy, you may not floss every day and then you pick it back up and the bleeding goes away, let's say. But if you have consistent bleeding or you have swelling of your gums, those are huge red flags. And in fact, everything that I do in my practice is I try to be very proactive and not reactive with patients, because a lot of patients unfortunately wait until it's too late to seek treatment. And there's a lot of reasons people wait. Scared, there's all sorts of reasons patients wait. But periodontal disease, which is the disease that I treat, is a chronic inflammatory condition which causes both clinical attachment loss, which means that the gums and bones start to basically shrink away. We want to protect that at all costs with good prevention, for sure.
And what is prevention? Like, what are a couple of things that people can do?
I think first and foremost is getting a good baseline at the dentist. So your regular dentist, not necessarily seeing a periodontist, but dentists can recognize periodontal disease and refer you out to a periodontist like me who specializes in the treatment and prevention of periodontal disease. So I think what's good is being proactive. So before things get to that red flag stage, right? So before all of a sudden you have loose teeth, you have abscesses, you have infection that you don't know about. If you're screened properly and see your dentist regularly, then a lot of that can be prevented for sure.
Sorry, Nadine, is that generally how it works? Like, say if I'm going to the dentist regularly, like I go to my cleanings every 6 months, I get a filling when I need to, can I assume that my dentist will refer me to a periodontist if they're seeing things? Okay.
Right. So, I mean, part of a complete examination is a periodontal examination. So we want to
Is this the one where they count?
Yes.
Oh, okay.
So that's the probing, right? So that probe, and a lot of people, if your dentist isn't doing it, that's a problem, by the way.
I don't think a lot do.
No. And
you know, it's funny because I've had patients that have been like, oh, I've never had that
Yeah.
done
Yes.
before. I'm thinking, oh my God.
why not? Yeah.
So
Yeah.
that is that is the most important factor in how we diagnose these things. So what that is, and I'll explain it to you quickly. So we use what's called a periodontal probe. So a periodontal probe is essentially a measuring stick, and it's in millimeters. In a healthy mouth, we have a sulcus. So where the gum meets the tooth, there's a little dip or a sulcus. And when we measure that, it's usually about 1, 2, 3 millimeters. Okay, so if you're at the dentist and you're hearing a lot of twos and so when we start to see gum disease is when that gum starts to separate away from the root of the tooth. And so bacteria starts to kind of creep down there, and we have an inflammatory process which causes the gum to separate away from the tooth, and then it starts to cause bone loss. So then we have inflammation. So the gum pocket is ulcerated. That's the bleeding. So what happens is when we're putting that little probe in there, we're starting to get deeper depths. So say 4, 5, 6, 7, 8, 9
Yeah. Oh,
millimeters.
wow. Okay.
So as that probe goes deeper, we know that the severity of the gum disease is going. So what's happening at the base of those pockets is that we're getting bad bacteria too. The good bacteria kind of are more aerobic in nature, so they like oxygen. The bad guys are the ones that are anaerobic, and they're in the deeper pockets. So that's when we start to see the change. So when your dentist is doing this examination, if they're seeing you start to have some mild or moderate pocketing, that's the time when you want to be referred out to a periodontist. Unfortunately, I see a lot of patients at the end stage of the disease, essentially, when sometimes we don't have treatment options, because ultimately gum disease is going to lead to tooth loss without treatment. But there are interventions we can take that can help prevent that. So you want to hear the numbers. The other parameters your dentist is going to look at is bleeding points. So how many sites are you seeing bleeding, right? Essentially, we want no bleeding sites. But again, through treatment, we can track bleeding and see if there's improvement. The other thing we're looking at is pus. A lot of times when I'm probing in patients' mouth, there'll be pus and they won't know it. It's funny to me because I try to explain to patients who, you know, otherwise are asymptomatic. They may have absolutely no idea they have gum disease, but they may have a ton of bleeding and a ton of pus in their mouth. If they had that type of infection on their arm, they would be at their doctor saying, oh my gosh, I have this pussy bleeding wound, I need help. But unfortunately in the mouth, sometimes it doesn't hurt, right? It doesn't hurt until it gets to a point where you've got a big
Can't
abscess.
taste it.
Some people, you'd be surprised. They just, maybe they're used to living
Yes,
like that.
right,
Yeah.
maybe.
But unfortunately, they think it has to hurt.
Yeah.
And it doesn't.
Right.
It doesn't have to hurt. And it can still be bad, right?
Right.
So,
Okay.
yeah.
One of the things, I go to Talia.
Yeah, we
and-
both do.
Oh, you do as well?
Yeah, I think that was the first time I had ever
Oh, yeah.
been anywhere where they counted.
Yeah,
Oh,
and they have their
see?
little
Yeah,
headset
she's really
on,
good,
and,
though.
and then they're talking into it.
Yeah.
One of the things, though, that I learned the last time that I was there was when they did the probing a year ago.
Yep.
Counted all the numbers, and then when I came back a year later, I did have some 4s, and I actually dropped the 4s by like half.
To 2s? To 3s?
I haven't.
Whatever.
I don't know.
So there's improvement.
There was.
Yeah.
And so that's
Okay.
one of the things I guess that I just wanted to say was even though you may start to go backwards,
Yeah.
there's an opportunity to fix it.
There
as well.
is. There's an opportunity to stabilize things for sure. And periodontal intervention, I mean, there's a wide range of interventions. Typically, our first line of defense are going to be non-surgical options. It would be like a cleaning of the teeth, right? You might be used to just kind of what we call a supragingival cleaning, where you've got the tartar on your teeth and they're just, you go to the hygienist and they're removing that tartar. When we get into more gum disease or those pockets are getting deeper, then we're getting onto the root surfaces of the teeth. So that is called root planing. So when we do root planing, we're essentially getting onto that root surface and we're actually taking off a layer of cementum. Cementum is a layer on the roots because the bacteria can actually get in there. So we want to plane that off and allow your body to reattach. So that's essentially what we're in a non-surgical treatment.
So like a deep cleaning.
Yeah, exactly. Unfortunately, as the pockets get deeper, our ability to get all that stuff off that starts to build up below the gum line in those 4s, 5s, 6s, 7s, those deeper pockets starts to go down. So that's where some surgical intervention comes into play. And someone like myself can go in there, open up the gums, clean everything out, and try to arrest the disease process that way as well.
This isn't one of the questions that I have on here, but this is obviously happening to guys. as well.
Yeah.
Do you also see?
Let's talk about that.
Sorry, guys.
We focus on women so much, but yes, this must happen.
No.
I guess because of the estrogen, it would be different. But
Right,
would we
so-
see this in men in midlife?
Yes, and gum disease is multifactorial. It's not just women.
And it's not just in
obviously.
midlife.
No. So when I say it's multifactorial, it's things like genetic predisposition. So I ask my patients a lot, and I say, for instance, did your parents have gum disease? And if they go, I don't know, did your parents have dentures? That can be a sign that they lost a lot of teeth, right? A genetic predisposition to gum disease is a high indicator that you are going to be probably prone to gum disease because it's the way our body handles infection. So it's a host-mediated infection. It's a chronic inflammatory disease. There is no cure for periodontal disease, but we can stabilize it. The other thing is smoking. That's a bad one. So smoking is probably the number one risk factor that I can't control. So when patients smoke, it really affects their mouth in many ways. So one of the ways is through those neutrophils, those cells that I told you about that I did my research on actually. So those neutrophils are like an army of defense. So they go out there and in response to bacteria, they're going in there and they're eating away at all the bacteria. They're also releasing products to break down the bacteria, which can also, in some cases, break down tissues if they're hyperactive, which in my research study, my patients were. So what smoking does to those cells, though, is it makes them really sluggish. So they're not as good at doing what they need to do. The other thing that smoking and nicotine can do is constrict the blood vessels. So we don't get the same response. We don't get the blood flow to the tissues. So smoking's a bad one. The other is just overall systemic health. Things like diabetes can be directly related to periodontal disease. And in fact, sometimes some of the first symptoms of diabetes can be gum disease. So I'll see in patients when I meet someone for the first time and I see disease, I'll often ask them, okay, when was the last time you had blood work done and had your A1C done? And surprisingly enough, a lot of patients don't realize they're either in a pre-diabetic state or they have diabetes. So that can also play an impact. The other is a lack of care.
Yeah.
So, and that's what we see a lot of, unfortunately. And there's lots of reasons why patients don't seek care. Could be financial. It could just be nerves. I mean, I've seen a lot of patients with good financial means that can let their teeth go because they're scared.
Yeah.
And there's ways that we can mitigate that. And in my practice here, and actually in Toronto as well, I focus on kind of stress reduction. And offer my patients different forms of sedation, which is so huge in the line of work that I do. Patients don't want to see me. I know that. And I don't want you to see me unless you really have to, but I want to be able to help you in a way that's going to be positive, right? And so offering sedation for my patients, I do a lot of IV conscious sedation on my patients. And I find that that will allow them to have the treatment, and then they realize, okay, this isn't so bad, and then they can seek treatment moving forward, and we can get them into a state of just maintenance. That's my goal with everybody. We want to maintain. Again, we want to be proactive, not reactive to these things.
What is it that makes people so nervous about dentists?
I
My
don't
mom,
know.
they have to drug my mom still to this day.
I
She
know.
takes a little blue pill. That's all I know.
Yeah, she
Really?
probably takes
Yeah.
triathlon. Yeah. So, I mean, I don't know. I think a lot of patients had bad experiences when
Like
they
when
were
they're
young.
younger?
Yeah.
Yeah.
So I think there's a lot of, and I see it today, even in practice, because I treat a lot of kids. I also work at a place in Toronto called Holland Blue Review. It's a kids rehab. It's a hospital in Toronto, so I work there, and I see a lot of kids from Sick Kids Hospital in Toronto as well. And there's a lot of parents that have their own fears about dentistry, and then
they put it on their kids?
Yeah.
Yeah.
So they'll come into my office and they're like, "Don't worry, it's not gonna hurt." I'm like, "Don't even say
Yeah.
that. Like, why are you saying it's gonna hurt? It's not gonna hurt. Like,
Yeah.
don't
Yeah.
say
Don't
that."
Put that in their head.
So I see that a lot. So I think it starts from a young age in a lot of cases. Maybe they had dentists that weren't as empathetic to their fears, which I see a lot of too. And I hear some of my colleagues and they'll say to me, "Oh, Andrea, my patients don't need sedation." I don't think that's the case. Like maybe you just didn't offer it to them, right? It's natural for you to be nervous for these procedures. I mean, I do them day in and day out, but I say to patients, this is new to you, right? So I want to make you as comfortable as possible. And in fact, if we can control that stress response, we actually have better post-operative outcomes.
Yeah.
So if you think about it, if you're not in that fight or flight, white-knuckled, cortisol's through the roof, you're all stressed out, if I can keep you calm during a procedure and you know that it's not going to hurt, and we can keep you comfortable and manage any postoperative discomfort, and we can sedate you throughout the procedure, then I find that patients recover better. They really do. So I think dentistry's got to change. I think we are changing. I think it's helpful that there's a lot more women in dentistry. I think we have a little bit more empathy. I really do.
I do too.
So I think
Definitely.
I think it's positive.
I just wanted to go back to the insulin resistance, the A1C that you were talking about before. It's so interesting because a lot of people wouldn't necessarily relate any of that.
Yep.
And also osteoporosis and also heart disease.
Yes.
And I know that we talked to Talia a little bit about the heart disease, but if you wouldn't mind kind of going into the connection with that, the connection with osteoporosis, or vice versa.
Yeah.
I guess I don't know which one comes first.
So we'll start with, for sure, diabetes. We can talk about that. So we see a direct relationship between glycemic control and periodontal disease, for sure.
But
So-
it's not as in like eating sugar every day kind of thing.
No, but what we see is that in patients who have periodontal disease, that may be impacting, if they're diabetic, that could be impacting their glycemic control. So when I get their gum disease under better control, we get better control of their glycemic control. So there's this direct relationship, right? With osteoporosis, I mean, we see that because of declining estrogen, we do see that rapid kind of decrease in bone density in menopausal women, which can affect their jawbones. And again, it's not every woman that's going to necessarily get osteoporosis in their mouth, so to speak, or in their jawbones, but in patients who've already had gum disease, they're definitely going to be more susceptible. Gum disease, like I said, is multifactorial, and so your bone turnover, bone loss in your mouth can be a result of bacterial insults, not just that you're losing bone because of menopause, but can affect treatment. I mean, a lot of my menopausal and postmenopausal women are on medications for osteoporosis, which affect our jawbones. And they're targeting those cells that are affected due to estrogen decline. So those osteoclasts, those ones that eat away at the bone, the osteoporosis treatments are targeted at those. So there's a couple of oral medications, they're called bisphosphonates, called Actonel, Fosamax. Patients residronate. Patients are taking these medications. A lot of women take them, but it can affect their jawbones too. So before you start those medications, we want to make sure that their oral health is really good. And so surgery on those patients, extractions, dental implants, can sometimes be complicated because it affects the healing of the bone. So we have to be very careful. And patients sometimes can be on these medications too long. Most patients should be on those medications for about 3 to 5 years. But some patients are on them longer because maybe their GP doesn't know any better. But anyway, it can lead them to be at risk for something called osteonecrosis of the jaws, which sounds awful because it's not great. It's dead bone, essentially, because it's affecting the turnover of bone and preventing those osteoclasts from breaking down the bone, so it kind of disrupts that system. So we see kind of poorer bone healing in those patients, potentially. It's not every patient, but it is a risk, and it's a risk I discuss with patients. So osteoporosis, for sure, can be linked. Heart disease, let's talk about that one. So we know that with gum disease, because it's a chronic inflammatory disease, it causes kind of a bacteremia or chronic inflammation into your bloodstream as well. So we see in those patients a higher level of, say, C-reactive protein, which is an inflammatory marker, or things like interleukin-6, which is an inflammatory cytokine. So we see in patients who get treated for gum disease, and we stabilize their gum disease, we see reductions in those markers, and that's well studied. So it's very related. We know that patients who have gum disease have a higher incidence of cardiovascular issues, and it all related because of the inflammation when you think about it. So controlling that can help control systolic blood pressure, endothelial health, which is how your vessels are contracting and relaxing, and reducing those inflammatory markers like the C-reactive protein and the interleukin-6, for example. So It's all related. So our mouth is very related to the rest of our body, and I think we need to stop separating it. So most of medical doctors get about an hour of training on oral health, really, in their whole medical career. So that's where your dentist and specialists can come into play to help guide you with taking care of that part of your body as well, because it's all connected. It really is.
So some women in midlife will start taking hormone therapy. Is there a correlation between periodontal disease and taking hormone replacement therapy? Does it help? Does it hinder?
So I would say it would help, because everything we talked about, so with our declining estrogen, if we start replacing that declining estrogen, of course when we think about it, it's going to help. Is there a lot of studies that show that? No. But is that because there's not a lot of studies?
Yeah.
I mean, it's like anything in menopause. It's really frustrating, right? So, I mean, personally, I can see a difference in my patients who have been on HRT compared to ones who haven't, in terms of their bone density and overall periodontal health, for sure. I know personally I'm on HRT and I notice a difference, right? So I think there needs to be more studies.
You notice a difference in?
My mouth was getting really dry.
Okay.
And I noticed that I had more inflammation in my mouth, which is weird as a periodontist, because I feel like I do a pretty good job of taking care of my teeth. So also I had more joint pain, which includes your temporomandibular joint, right? So we know that. I mean, estrogen can be quite protective. Like when patients who have TMD, or temporomandibular joint dysfunction, for instance, in pregnancy, when you have tons of estrogen, a lot of times that goes away, right? But in menopause, sometimes we see an increase in that, or an increase in facial pain as well. So yeah, I mean, I think that there needs to be more studies. I don't think there's a lot of data to support it, but I think that we need to start looking at it as part of our patient's complete risk factor profile, right? So I think it's important to talk to your family doctor. I mean, as a periodontist, I can't prescribe estrogen to you,
right?
But I can encourage you to talk to your doctor about it, and I can encourage you to bring up the things like osteoporosis, cardiovascular risk, you know, all of those things, potentially diabetic issues, with your doctor, and how, if we're seeing signs of problems in your mouth, that could be one thing to talk to your doctor about, for sure.
I just want to go back to a few of the things that we've already talked about. Let's talk about this one right now, though, the saliva. Like you had said that during menopause, there can be the dry mouth and decrease in saliva. What can women do about that?
So there's quite a bit you can do about that, actually. So we know that obviously saliva is very protective in nature, right? So we want to hydrate. That's number one. A lot of people are very dehydrated. So obviously getting enough of your fluids. Number two, there are things that help stimulate saliva. Xylitol is one of the things that I really like, and I recommend to patients as well. So there's little candies or gum made of xylitol. Even at nighttime, there's these things called xylomelts. It's actually a cool product, and you kind of stick it to the inside of your gum, and it's a slow release of xylitol at nighttime, and it can help kind of stimulate some of that saliva back. So you also want to be careful. You want meticulous oral hygiene too, because when we have that lower saliva flow, we're going to be at increased risk for dental decay and periodontal disease. Fluoride becomes important. I am a big believer in fluoride, topical fluoride anyway. So in some cases, when I see patients who are very xerostomach or have very dry mouths, we're getting them into high-dose fluoride treatments, either that with over-the-counter types of things like Periodontal, which is a toothpaste they can use once a day to actually help remineralize or harden the tissues. So that becomes really important too, because dental decay can be quite devastating. And when you're postmenopausal and you've got a dry mouth, or potentially you're on certain medications that can cause it, right? So as we age, unfortunately, we tend to see people start getting on different medications as well. And virtually every medication, if you look at some of the side effects, it's going to be dry mouth. So when patients are on these medications, we want to encourage them to keep up with their dental health, fluoride if needed, and also using these stimulants for saliva like xylitol are really good.
Okay, yeah, that's great. And the other thing I wanted to come back with stress, because women in midlife tend to be stressed a little bit. How does stress and cortisol, the increase in cortisol, affect gum health, gum disease and healing,
right?
And coming back from that?
So I think it affects things in a couple of ways. Number one, we see behavioral changes with stress, right? So when patients are stressed, they're not taking care of themselves, right? And a lot of women, unfortunately, I think we take the burden of everything, family, kids, aging parents. I mean, in midlife, it's a hard time for a lot of us, right? And I see that with my patients. So they may not be brushing as well. They may not be getting the sleep they need. They may not nutritionally be feeding their body what they need. And they may be drinking more or smoking more. I mean, there's a lot of behavioral patterns that we see with stress. But we also see a shift from a host perspective to that pro-inflammatory state with increasing cortisol levels and things like that. So, I mean, stress reduction, I talk to my patients about that too. I mean, I think it's really important that we focus on trying to reduce stress because it has been linked to gum disease. And it actually psychological stress and stress in general has been linked to poorer healing. So poorer healing results for my patients who are stressed out, right? So I'll see it sometimes, patients come in and all of a sudden their mouths don't look like they normally do. They could have an increase in bleeding, there's puffiness, and I'll say, is everything okay? And, patients say, oh, actually my husband was just diagnosed with cancer, or, my kids I'm an empty nester now, my kids have left, and, I'm taking care of my parents, my father's in a nursing home. You hear stories and you start to understand that, stress can really have a factor to play in this. So it is both. So we see the behavioral changes, but we also see definitely a shift in our bodies in terms of how we handle inflammation.
Yeah. So back to nutrition then. What role does nutrition play in periodontal health? And are there specific nutrients that women in midlife might be lacking?
So I think we're finding more and more the importance of that anti-inflammatory diet, right? So maybe a Mediterranean diet focusing on getting enough protein. I think we're probably all not getting enough. Well, I try, but sometimes it's hard to get a lot of protein, but we need to focus on that for sure as women. Vitamin D is super important too, and I find that a lot of people are deficient despite they think they may have a great diet.
Even here on the island, everybody thinks because we have the sun 24/7, basically, that we're not going to, but a lot of us are deficient in vitamin D.
So having that tested, and that plays such a huge role in bone metabolism, right? So an anti-inflammatory diet for sure, getting enough fiber, because we need the prebiotic fiber, right? Because that's really important to your not only your gut microbiome, but your oral microbiome too. So I think in general, if you have a healthy diet, you're going to hopefully be getting enough vitamin C, so we don't see scurvy these days, but that back in the day used to be a problem, right? So, I encourage patients to get a well-balanced diet. After I do surgery on them, I really encourage them to make sure they're getting adequate protein for sure.
Yeah.
Because some people think, oh, I just have to be on liquids after I have dental surgery. I'm like, no. Like, make sure you're eating your scrambled eggs. You can have fish. You can have lots of things that can increase your protein intake. Cottage cheese, yogurt. There's lots of things that you can eat. But yeah, nutrition definitely plays a role for sure in overall health, but also in oral health. Really, what's good for your heart is going to be good for your mouth too.
So we are going to our dentist. We are making sure they're doing the periodontal screening.
Yep.
How often should the screening be happening?
I would say at least once a year. So having an annual assessment, and if you're going for your cleanings, the hygienists are now pretty well trained to do that screening as well, right? So your dental hygienist becomes a really important player as well, because they're typically updating your charting. Even if they're not telling you, they may be doing it.
Yeah.
And you can always ask them, hey, how are my numbers today?
Yeah,
right?
that's a good idea too.
Because we need to take ownership of it too, right? So if there are places where, say, you're getting a 4 or 5, like, let's work to get those down.
That's good to know. And a lot of things we talk about on the podcast, we encourage people to advocate for themselves and to ask questions and to so I think that's really great advice, because I might just go to the dentist and not hear the numbers and assume, well, everything's fine, but it doesn't hurt to say, hey, did you check that out today? How does it look?
Yeah.
Anything I should be
Yeah, working on. Yeah.
Any higher numbers or anything.
Yeah.
Like, why not ask? It doesn't.
Yeah.
It doesn't hurt to ask.
It doesn't hurt. And to understand what that means, what
Yeah.
those numbers mean. Because patients will ask me all the time. I mean, I do it so routinely, multiple times a day. I'm just, 3-2-3-3. And patients are just kind of looking at me, is that good?
Yeah.
I'm like, oh, no, you're good.
Yeah.
And I always tell them, if you hear the high ones, that's bad. So higher
Right.
scores are not better in periodontal health. So,
You don't want a high score.
Yeah, you don't want that.
I just have one final question. If you could give every woman in midlife one proactive step to protect her gums and oral health through menopause, what would it be?
I think number one is to be proactive. That's all. I think I want to focus on that. So obviously finding out your status now, right? So we want to go in, if you're perimenopausal and you're going into that menopausal change, we want to be proactive. We want to ensure that we're going into that with optimal health, right? So, and we want to do things to reduce our risks of bony changes too. So does that include HRT? My opinion, yes, right? Does it include ensuring that you're doing an adequate job of brushing your teeth and interdental cleaning, which is super important? I'm a big fan of electric toothbrushing.
I was going to ask.
Oh, yeah.
Okay.
I love them.
Yeah.
So my favorite is the Sonic Care. I wish I worked for them because I would like, anyway, I've been using mine for 25 years. So the Sonic Care toothbrush I find to be an incredible tool for patients. Number one, it kind of keeps you honest because it stays on for 2 minutes, right? So most people brush their teeth for, I think it's like 17 seconds or something like
Really?
that. Yeah, it's really bad. So
Especially if you're in a rush trying to get out the door in the morning.
Yeah.
Go.
Yeah,
It's a lot
but the
Yeah.
electric toothbrush, really, you should just use it until it stops. So that's about 2 minutes. Number two, it's moving at about 60,000 brush strokes per minute. So it's giving that kind of, that's why they call it that sonic effect. So it's kind of disrupting that plaque biofilm, breaking it up, and getting your teeth cleaner. So toothbrushes like that are actually clinically proven to help reduce those pockets as they are, just mildly inflamed. So that's number one. Number two, which I'm really liking these days, is water picking, actually. So water flossing, water picking, they're great too.
Would that replace flossing?
No.
Okay. I'm glad I asked. Okay.
So you still have to floss. So
Okay.
I'm just making it longer for you.
Yeah.
So flossing still is great because flossing actually helps to get rid of the plaque below the gum line. So when you're flossing properly, you're actually kind of doing this kind of C motion where you get kind of under the gum and you're pulling stuff out. So I still think flossing is important, and flossing is important to help prevent interproximal, which is between the teeth, decay.
Yeah.
So that's really good. But the action of water flossing is really good, and actually really good around dental implants, which I do a lot of. So we help flush out any bacteria that's building up around dental implants very safely with water flossing, so water picking. So I think oral hygiene aids are really important. I think that making sure that if you start to notice that you have a dry mouth, speak to your dentist about different things. You want to make sure that you're preventing problems again. There's some neat stuff coming out, and actually my research supervisor from the University of Toronto has developed a new probiotic. It's in clinical studies right now, Princess Margaret Hospital in Toronto, and also at the dental school. And it's really neat because it's a probiotic that is quite unique. It's a bacteria that's only found in healthy mouths, and it produces this protein that is basically antibacterial in nature. So it's going to act to kind of kill the bad bacteria in your mouth, but promote the healthy stuff.
Yeah, right.
So when it becomes available, I am going to get all my patients on it because it'll just be like a daily, basically like a lozenge that you would have in your mouth. So I think that's kind of neat too in the future of periodontics and dentistry, that we really want to focus on the microbiome. Again, I think I said at the beginning, we used to concentrate on trying to kill every bacteria in your mouth, right? And antibacterial rinses and antibacterial this and antibacterial that. Well, we still want to keep some good bacteria, right? So a little bit of a shift in that way too. So I think there's lots of things you should talk to your dentist about in midlife for sure. And just ensuring that you have a good baseline going in. It's important.
Yeah.
What's your thoughts around mouthwash, like Listerine and stuff?
So again, because we find that patients actually who use daily mouthwash can have an increase in blood pressure, right? So there's bacteria in our mouth that help produce the nitric oxide. So I don't think daily mouthwashing is needed, right? If
It will increase a person's blood pressure?
It can, because it affects the bacteria that produce that nitric oxide. So it's interesting because and you wouldn't
Didn't
think
know
that
that.
could be an issue, right? So I would say no. I mean, post-operatively, I get my patients on just saltwater rinses, and usually just for a couple of weeks, right? When I first graduated, we put patients on chlorhexidine, which was a very strong antimicrobial mouth rinse. I don't use it at all anymore. So I think we're shifting again, right? So yeah, I don't think that you need to use daily mouthwashing. Some people are using mouthwashing because they have a bad taste or they might have bad breath. Well, that could be masking periodontal disease, right?
Yeah.
So patients who are using these things probably need a better evaluation of what's going on, because you may have gum disease in there and not know about it, right? I like tongue scraping. That's a good one. So tongue scraping helps remove a lot of that bacteria that's building up on your tongue as well. And most of the time, about 80% of bad breath is caused from the tongue. So you could scrape your tongue every day. You can buy those little copper scrapers and stuff. I think that's a good practice to be in. But I wouldn't say mouthwashing should be done every day at all.
Are things like the gum grafting, is that simple, easy, invasive, less invasive?
I mean, I think it's simple.
Okay.
But I do a lot of
I heard it's a little painful.
Yeah, so
Yes.
I hate hearing that because it's not necessarily painful. There's ways that we can really reduce your pain. Okay, so first of all, when I do gum grafting, I'm using kind of microsurgical instruments and things like that. So we're trying to reduce trauma. That's number one. Number two, I do a lot of them under sedation. So my patients actually heal better, and I'm able to give them an intravenous dexamethasone, for example, which helps with swelling and things like that. So there's also proteins that I use during surgical procedures that enhance wound healing. So when I do gum grafting, I'm using a product all the time called Emdogain. Emdogain is a really neat protein that stimulates your body to produce new cells of attachment. And it's neat because it also just kind of speeds up the cascade of healing. So when I use that, it's clinically proven to reduce post-operative pain and swelling. So I use that with all my patients, and so I see a difference with that. I also use this kind of protective wax that we just put a little bandage on the roof of their mouth where we have to take the tissue from. And that wax just stays there for about 6 or 7 days, and it helps protect that area. So most of my patients actually don't complain about pain. I usually tell them, listen, you're going to have to expect a couple of days of discomfort. The most annoying part of gum grafting is that you have to have probably a softer diet for a couple of weeks. And so when someone tells you you can't eat something hard and crunchy, what do you crave? Hard and crunchy things, right?
For sure.
So I find that becomes a bit of an issue. And the other thing that patients complain about is I tell them they can't really do any big exercise for about a week. Because when we get our heart rate and blood pressure up, we can pop little vessels and you can bleed.
Right.
And I've had a few patients with pretty significant bleeds in their mouths. So that for active women can be hard to tell them not to do anything for a week. I mean, you can do light exercise, go for a walk and stuff like that, but you're definitely not doing any like strength training or anything like that. But it's a week. It's a week. So gum grafting is not that bad, especially when patients let me sedate them.
Yeah.
I find that they're fine. So I find that...
And if the alternative is to lose a tooth eventually, we don't want that. So
that's just it, right? I mean, there are tooth replacement options, but nothing, in my opinion, is as good as your teeth.
Yeah.
So dental implants are a very highly successful and predictable treatment. However, they're not perfect, right? So we can see issues with dental implants. We can see gum disease around dental implants. We can see bone changes around dental implants in osteoporotic women. So we can see risk factors increase by placing implants in osteoporotic women. So anyway, there's, so anything we can do to try to save teeth, I'm all for it. But we need to get patients past the fear of it and the stigma that it's going to hurt. Because we can there's definitely ways that we can control the discomfort and make it as smooth of a process as possible.
One of the things that we talked about quite a bit with Talia when she came on the podcast was how there is, I guess, a perception or a conversation that a lot of women in midlife are losing teeth, and that it was like, quote unquote, normal. It's like happening. And Talia was like, no, it's not normal.
I know, it's not normal. It's not normal at all. And that whole long in the tooth, like patients just think like, oh, well, this is part of aging. And it's not, right? And those are signs that it's not normal. So no, I wouldn't. I mean, I heard someone say for every kid they lose a tooth.
Yes, I've heard that too.
Okay, like that's not good either, right?
Yeah. You got 5 kids. I guess I'm going to lose 5 teeth.
Exactly. No, so we definitely, that's not normal. That's not normal. And we can keep our teeth well into the rest of our life, you know.
That's great. And I think just having these conversations and getting that information out there so that people are aware that there are these things that we can do to stay on top of it and to help prevent it.
Yeah.
So that we don't have to lose teeth or even have any of the surgeries. Like obviously we don't want to have to do that either.
Yeah.
So this was great.
Yeah.
This is very helpful information. So you're visiting dentist. So you are here. How often are you here?
So 4 or 5 times a year.
Okay.
And when I come, I'm here for like 14 days at a time. So I can see patients at my island dentist, obviously. Working with
So can
David's
people
end.
just like call up my island dentist and ask to see you while you're
so
here?
We take referrals as well from other dentists on island as well, just like my office at home. So my office at home in Toronto, it's all referral based. So patients find me. Some patients find me on their own, either word of mouth or internet or things like that. But most of the time, it's from a dentist. So
if there are people in Toronto or in the surrounding area and did want to come see you, how could they get in touch with you there?
So my office is called Johnstone Periodontics, and if you're from the Toronto area, it's right at Yonge and St. Clair. So we have a website, johnstoneperio.com. So my practice is kind of neat. You guys would like it. It's all women. So I have 3 incredibly talented associates as well, all periodontists as well. So there's 4 of us, 4 periodontal specialists at my practice, and I even have a female anesthesiologist on staff as well. It's fairly unique in that sense that it's kind of an all-female, female-led and female specialist practice in Toronto. So you don't necessarily need a referral from your dentist. It's not like a specialist in medicine where you need a referral from your GP. I like it because I like to work with dentists. However, if there's a reason that you think you need to see a periodontist, you can definitely make an appointment to be seen. If you're worried about gum recession, if you're worried about a missing tooth, you want to replace a tooth, then by all means you can make an appointment.
Yeah, great.
Perfect. Well, thanks for coming on.
Oh, thanks.
Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!